Okay, one of the things I've started to get interested in teaching is to say to our students, like, what's the next best question? And with things like the red rash made easy, the best question is it very itchy? Because there's only 4 things that are very itchy. There are 4,000 that are not. So which domain do you want to be in? The 4? You can start guessing there. With the 4,000, you need a dermatologist. So I've become quite interested in the next best question. So if a patient comes in and they're not sleeping well, low energy, poor concentration, what would the next best question be? Okay, the likelihood of having a mood problem is going up, and in evidence-based language, the pre-test probability is going up to the point you can start making things. So I'd like to know their mood. And this is the EMOQOL. So I want to know your emotional quality of life. If 100's perfect and 0 worst imaginable, where are you now? And some people have a bit of trouble with that, in which case I say, well, what's your mood like? How are your spirits? How are things going? I've just started doing a bit of work at the City Mission where people aren't don't have health literacy to the same extent as in Manurewa, but most people sort of get that. Somebody asked me if English isn't their first language. Well, you're going to have problems with questionnaires anyway unless it's being translated into, or you can speak the language. So sometimes I do have to explain that. But, and the interesting thing is when we first did this, we sort of thought 50 would be the median, but it turns out to be 60. The first thing we published, we looked at 50 as the cut point. But I was finding when I was seeing patients, a lot of people, even when they were 60, would have still a mild low mood, not a big one. If they're less than 20, and this is the second study we did, they are very flat. They are 25 times, it's almost slam dunk. We don't get, so that's a term for that is the likelihood ratio. You don't get many likelihood ratios of 25 in clinical medicine. You're lucky if you get under, up around the 10 range. So it's very, very big. So you really know somebody's got a low mood when they're down like that. And they will probably look like that too. It would be no surprise. So I can guess now what the PHQ-9 is going to be. So when I'm billing in counties, I can just literally, I don't have to do a full PHQ-9, I just guess it. Because I don't want to spend 5 minutes fluffing around with a PHQ-9. I want to talk to the patient. So, and counties aren't interested in their mood. They're interested in, have you seen the patient and done that? So, and so once somebody's 65, they're fine. So I originally started doing it just to monitor patients, but I found actually it was a pretty good assessment. In a single question, only got 15 minutes. This is 15 seconds. So I did start, when I originally started, I asked patients their quality of life, because this is, those of you who are familiar with the EuroQOL, this is a sort of a takeoff of that. And this patient said her score was 30, but her mood was okay. And I sort of said, well, what's the problem? This lady had a chronic pain problem, so her quality of life was low because her pain, but actually her mood was okay. So I figured, I need to change it to emotional pain. So that's where the word comes. And I don't like words like depression or anxiety because they're really big labels. And as I say to my students, if you break up with your boyfriend or girlfriend at 20 and someone puts major depressive disorder in your notes, it'll be there when you're in your rest home when you're 99 because nobody will take it out. Okay. Don't have to read, and remember some of our patients can't read, and they won't tell you. You won't know how many of your patients can't read. I've discovered a few in my career. Very few people will admit to being illiterate. No glasses takes 15 seconds and it's valid. There's limited experience in teenagers. I find they sometimes are a bit all over the place. And sometimes with elderly people over 80, they don't do well on questionnaires. Hasn't been tested in pregnant women, and we're just doing a study now on screening from the waiting room just to see if that changes it. People need a reasonable grasp of English. I wouldn't try this if somebody didn't. But that's true for all questionnaires. So it can potentially miss. Sometimes somebody will have a normal EMOQOL. It's pretty rare to have a pure anxiety. I know David Kadai has always been onto that. It's unusual. Psychiatrists seem to be the only ones who see pure anxiety. GPs seem to see mixtures of it. But I find with the anxious patients, it's pretty obvious. They come in, I just want to get rid of it. This is awful. Get rid of it for me. And of course, the problem with anxiety is when you've got a high control agenda. If you've got it, if you don't want it, you've got it, is one of the sayings. So you can use this. This is the GAD2, which is the PHQ-9, but for anxiety. And so a score of 3 or 4 would be. So that's another option. The other thing that anxious people say is they don't say it when the mood's low, is I think I'm going crazy, which is rather nice because you say, well, you think you're going crazy, you're almost certainly not. So that's actually quite easy. I just came across a term the other day, that depression and anxiety, another term for them is internalizing disorders, which I thought was quite a good description of them. They really travel together in primary care. We rarely see people who are different. The treatments are the same. And although occasionally you can see anxiety alone, and as I say, the patient usually tells you about it, so I'm rarely surprised. That, just to remind you, that's the PHQ-9, which I stopped over COVID using it on the telephone, because you try asking that question 8 down there on the telephone. You know, it's hard enough to say to a person in front of you, but on the telephone it just, you know, you just give up. Okay, so I think, well, why do we need to sort out mood? Well, we're always trying to sort out the physical from the psychosocial in primary care. And as I say, for billing, I can guess the PHQ-9, and you can't tell by talking to the patient. I have a lady, she's born in New Zealand, but she's originally she's Niuean ethnicity. And when I was playing around with the 2 questions for depression about 20 years ago, she's always laughing. She laughs in the waiting room. She jokes with everybody. You think she was the life and soul of the party. And I said to her, have you felt depressed, down or hopeless for all or most of the last month? Yes. Have you lost interest and pleasure, all activity? Yes. She's been like that for 20 years. I still know her. And she's just had awful things happen in her life. And but she keeps a very brave face. As Robin Williams said, people don't feign depression, they feign normality. So you want to see if your treatment's working. So that's why I did this in the first place. If the treatment's not working, we need to add talk therapy. And I don't know how many of you are using Just a Thought, but I'm referring virtually all my patients now to Just a Thought. If you invite people to it, they are twice as likely to do it if you don't. So I try and email them, although their email system's not working too well at the moment. Yeah, and if they're getting talk therapy and they're not getting any better, that's when I'd add medication. I virtually never give antidepressants at the first visit, basically, because we know with behavioural activation, 50% of people are better a week later in primary care. We've done a trial in our clinic, so we know that. That's just the options with Just a Thought. So that's just a list of patients I have to refer them to those things, you know, like the obsessive compulsive disorder module for a patient. So that's always interesting. Okay, so why we measure mood? Well, if they actually truly are up in the severe range, we probably need to be giving drugs and talk therapy. So severe depression, we don't see much of it in primary care. Most of this, remember we're seeing people on the worst day of their lives? None of us look very good on the worst day of our lives, okay? So behavioural activation in the trial we did is it always include exercise. Everybody I see gets exercise. You know, I'm obsessed with exercise. They need to catch up with a friend because these are the things they will have stopped doing. We've got very good data on this. People, and we do it, that's what we do as humans. Get distressed, stop seeing our friends, stop exercising, stop doing pleasurable things. So those are the 3 things of behavioural activation. 46% of people are out of a low mood situation in a week in primary care. If they're not improving by 4 weeks, well, we need to add in something, maybe retrack the diagnosis. There may be a personality issue. That's the one advantage of a PHQ-9. If people tick everything on the right-hand side, they probably have a personality issue rather than it's a nice little trick to know. That would be a business, because they're trying to show you how bad life is, and of course it is bad, but not in the way that I think. Or get another clinician to see somebody. So, because I realise I'm an older male doctor, people may not particularly want me. We may not be connecting, all that sort of stuff. So, summary, I want to know your emotional quality of life. 100's perfect, 0 worst imaginable. 60 or less is associated with a low mood. And the lower it is, of course, you get down to the 20s. Our clinic has a little bus. It's a camper van that goes around South Auckland providing care to people who are in emergency housing, basically. And I was down at the Takanini probation office, and there was this 35-year-old woman there, and she was talking, she was smiling, and we had quite a good conversation. And I asked her this, and her score was 30, so straight away I knew she had a low mood. I was then able to link her up with some sort of support services. So it just really speeds things up. It's the quickest way, it's the only single question way to think, and it can really alter the consultation direction and assist with diagnosis. There's a paper version at brucearrell.com, which is my website. I also have a handout there called Rules for Life, because it took me about 35 years to basically figure out how to run my mind and life. It's got a title called Running Your Life and Mind Effectively When There's No Instruction Manual. Because the problem with us when we were born, our parents weren't given instruction manuals. And neither were we when we became parents. So, but also I'd suggest also with Just a Thought it's a New Zealand-based CBT thing. It's based on an Australian model and it's free for the patient. That's a little southwestern penguin photograph of my wife. So, any questions?